Professor of Vascular and Endovascular Surgery in Mansoura University. He will talk about chronic iliofemoral venous occlusion, hybrid revascularization or bypass.
As we look for the severity of iliofemoral DVT, we will find that going with a very high risk, especially when the occlusion involves both the iliac and the femoral, the common femoral system. And this debilitating PTS could happen in around 50% of the individuals, leaving some of them in around 90% with venous insufficiency, 15% with ulceration, 15% with venous claudication, and 40% with impaired quality of life. Looking to the pathophysiology of these individuals with the main problem of the ambulatory venous hypertension, particularly is severe when valvular and obstruction coexist. And as the valvular function can be assessed with Doppler, we will look at the residual venous obstruction which goes undetected, leading to under appreciation of its contribution to the PTS morbidity. When we go through the escalation in the system of typing from type 1 to type 5, with starting with the mechanical compression by the May-Turner syndrome, and then involvement of the whole iliac system, followed by the involvement of the common femoral, and then extension to one of the deep femoral or superficial femoral or both together, we will find this escalation of the system has its impact on the severity of the PTS, as well as its impact on the strategy for management. For example, if from type 1-3, we can manage these cases with endoluminal revascularization and stenting, while in type 4 and 5, we will need endophlebectomy with a hybrid technique. We have to go through the assessment system of the PTS first by using a various scoring system ranging from the VCSS to the Villalta score, and encroaching towards the SEEB, and lastly with the veins quality assessment score. And taking these 10 points in the VCSS and the 11 points in the Villalta score with a highest score of more than 14 or the presence of a venous ulcer, we can go through either the conservative treatment of the mild cases and moderate cases, and we can have a better assessment if we don't get a satisfactory improvement with the conservative treatment. And with the assessment, we may find that the patient is having either a reflux or a non-acute obstruction of the system. So in the cases of the reflux, we can treat accordingly by sepsis or venoplasty or vein transposition, or we may go through a kind of venous ablation of the superficial system. On the other hand, we have from type 1 to type 3, we can go through the iliofemoral stenting by proximal crossing, either through the popliteal, the femoral, saphenous, contralateral, or jugular approach. And once in one type 1 and type 2, we have to stent from healthy to healthy, while in type 3, we got to extend our stenting system to the common femoral vein. Looking at this area, stenting from healthy to healthy, we have to extend from up to 1/2 to 1 centimeter inside the IVC, and extending to the most healthy part of the common iliac system without skip lesions, having a bridging of 1 to 2 centimeter in between, and we have to assess for total disappearance of the collaterals by a perfusion scan. We have to have a one trunk with good inflow ending in a good outflow inside the IVC, with a very good outcome by complete healing of the ulcers within a couple of weeks. Looking on the extension of the process towards the common femoral vein, we have to have certain points that should be emphasized on. First, we should use a dedicated stent in the case of involvement of the common femoral vein. We should not extend our overlap into the below inguinal ligament, and we have to emphasize there is a high risk of stent occlusion when we extend below the inguinal ligament, and we should not encroach toward the deep femoral vein because this may entail jeopardizing the PTS symptoms, and we have to exert the highest effort toward crossing the common femoral vein by different kinds of CTOs and extension of our process more proximally toward the IVC. And when we stent the iliac system and the common femoral system, we may achieve a primary patency of 57% with assisted primary in 80% and a secondary patency of 86%. But again, in the presence of extension below the inguinal ligament, there is a 3.5, 3.8 fold increased risk of stent occlusion. And in such cases, disappearance of the collaterals is mandatory, and if the collaterals didn't vanish in front of you with a single trunk into the IVC, you have to extend your stent more caudally. In type 4 and 5, we got to go through an endoflebectomy and then proximal crossing towards the IVC. If we succeeded, we have to stent the iliac system, and in case of failure, we can jump toward a palm operation or bypass using either the saphenous vein in case of a good vein quality of 5 millimeter or more, or a synthetic graft if we have a poor quality saphenous vein, using either arteriovenous fistula in adjunct or not arteriovenous fistula, depending on the adequacy of the inflow and depending on the quality of the graft available, and again in the presence or not of thrombophilia. So in a case of type 5, in such a case we don't see any of the common femoral, the deep femoral, the common femoral vein, or the iliac system are totally absent. And in such a case, we got to go through an endoflebectomy, and we have to assess all the, to remove all the fibrotic material inside the vein until we reach a healthy area. And this is much more difficult than the thromboendoarterectomy of the arterial wall, because there is no aligned demarcation between the fibrotic material of the thrombotic material and the vein wall. So you have to be very meticulous because you may injure the vein wall at that time. Sharp and blind dissection are mandatory, and you got to conclude your procedure by assessment of the inflow from the deep femoral as well as the superficial femoral vein. In a straightforward cases with endoflebectomy, you can close the patch graft. This patch graft may be a saphenous vein or a synthetic vein if you don't have good quality of the saphenous vein, and then you go through more proximal towards the iliac system by dilatation and then stenting, and you have to extend the stent toward the site of the patch graft downward in your field of inclusion. You have to assess this a good inflow and a good outflow toward the IVC, like in such a case. If you do an endoflebectomy and it turned out by assessment of the inflow and the outflow, you have a good inflow on both sides, and then looking more proximally towards the, now you can see the inflow from the deep femoral, and again on the right hand side you can see the inflow from the saphenous system. Again, the saphenous system is very important because it acts as a good adjunct in such cases. Proximal extension will find a local stenosis, a stenting of the stenosis, and then a residual stenosis that can be further stented with a good inflow and outflow from this such site. If you have a poor inflow from the deep system of the deep femoral and the superficial femoral, and you don't have an access like on the right hand side, you can see this is a poor inflow that cannot support your stenting situation, then you have to consider bypass to the contralateral side. And this bypass can be used in consuming the saphenous vein from the contralateral side and bridge it in the suprapubic region, and we can use as a bridge graft. Part of the vein is connected as a patch graft to the original vein, and the rest of the vein is connected to a branch of the superficial femoral vein. And if you don't have a good quality saphenous vein, you can grow through a synthetic graft with an arteriovenous fistula, making a loop with a mark on it. Then you can close it with a very good improvement of the venous ulcer in a couple of weeks. And taking home message, the patency of the reconstruction of open surgical is affected by the quality of the conduit, the graft material, the venous pressure, and the thrombophilia, which is a common situation. The endovascular procedures are a viable alternative when we fail to do endoflebectomy in such cases, and the Palma procedure gives an excellent outcome with a good symptomatic relief. In cases of May-Turner syndrome with a mechanical occlusion, the outcome is great because it is a non-thrombotic. On the other hand, in the thrombotic cases, we have an incidence of 14% with occlusion and 10% of in-stent stenosis. And lastly, poor outcome can be expected in the presence of a long femorocaval venous obstruction. Thank you.
Thank you, Professor Musad. Now we shift to Professor Ayman Salim, Professor of Vascular and Endovascular Surgery at Zagreb University. He will talk about recent guidelines for management of deep vein thrombosis.
السلام عليكم جميعا. معلش من rearrangement في خلال الفترة دي I would like to thank my dear colleague Professor Dr. Musad Siliman and all organizers of this conference for inviting me for this conference. I will talk about recent guidelines for DVT. The agenda for this presentation, I'll comment the guidelines for unprovoked DVT and provoked DVT and proximal, lower extremity DVT, upper extremity DVT, and special populations, pediatric pregnancy, cancer-associated high-risk thrombophilia, chronic kidney disease, underweight or overweight patients. Venous thrombosis clinical practice ESVS 2021 designed the guidelines I'll present for you. First, in the setting of suspected DVT, use ultrasonography as the first modality. Outpatient management is recommended for the most of DVT cases. In case of unprovoked DVT, the ESVS recommends clinical examination and sex-specific occult malignancy screening versus routine extensive screening. Reassess the patient bleeding risk before continuing anticoagulation longer than 3 months. Unprovoked DVT. For unprovoked DVT, the principal treatment phase for the patients with unprovoked DVT use direct oral anticoagulant DOAC is recommended over that of low molecular weight heparin followed by a vitamin K antagonist. In addition of these patients who have a low moderate bleeding risk, extended anticoagulation past 3 months and periodically assess the bleeding risk. For patients with second subsequent unprovoked DVT, extend anticoagulation therapy for longer than 3 months. For patients with provoked DVT and major treatment risk factor, use 3 months anticoagulation treatment rather than shorter duration. Direct oral anticoagulant is recommended over the vitamin K antagonist for the principal treatment phase. During the essential principal treatment phase for the proximal DVT, in the setting of existing contraindication to anticoagulation, insert a temporary inferior vena cava catheter. Only in this indication, not in all cases. Apply early compression within 24 hours, and those with proximal DVT at 30-40 millimeter mercury with earlier multi-layer bandaging or compression stocking to reduce pain, edema, residual venous obstruction. For patients with proximal DVT who have limited symptoms and signs based on Villata score, limit the use of below-knee stocking to 6 to 12 months. For symptomatic calf DVT and the lower extremity DVT, for symptomatic calf DVT that requires anticoagulation treatment, 3 months therapy is recommended over shorter duration. For those with symptomatic calf DVT not receiving anticoagulation clinically, reassess and repeat whole leg sonography after 1 week. For calf DVT, direct oral anticoagulant are recommended over low molecular weight heparin by vitamin K antagonist. In the setting of suspected lower limb superficial vein thrombosis, obtain a whole limb sonogram to determine the extent of thrombus and roll out asymptomatic DVT. For patients with lower limb superficial vein thrombosis that is less than 3 centimeters from the junction of the deep veins, use therapeutic anticoagulation. More than 3 centimeters away from the junction with deep veins and extends more than 5 centimeters in length, treat with from the Paranix 2.5 milligram once daily, extend more than 5 centimeters in sonographic length, and extend more than 3 centimeters from the junction with deep veins that with 45 days of anticoagulation. Upper extremity DVT. For patient with suspected upper extremity DVT, use ultrasonography as the initial diagnostic modality. For primary upper extremity DVT with 3 months of anticoagulation. Pediatric DVT. Management of pediatric DVT should be guided by clinician with specific expertise in pediatric thrombosis and hemostasis. During DVT, during pregnancy, should be managed with therapeutic doses of low molecular weight heparin for at least 3 months and at least 6 weeks postpartum. Cancer-associated DVT. In the setting cancer-associated DVT, use low molecular weight heparin for initial and principal phase anticoagulation. For those with active cancer-associated DVT, switch from low molecular weight to oral anticoagulant after 3 months, 3 to 6 months of therapy for extended treatment. DVT with high-risk thrombophilia. In the setting of DVT and high-risk thrombophilia, antiphospholipid syndrome, homozygous factor V Leiden mutation, or deficiencies of protein C or S, antithrombin, treat with full-dose extended anticoagulation and reassess periodically. Long-term follow-up by thrombophilia experts is recommended. DVT with chronic kidney disease, use low molecular weight heparin, fondaparinux, direct oral anticoagulant, reassess renal function periodically. Underweight or overweight. For underweight or overweight patient with DVT that requires anticoagulation, adjust the dose of unfractionated heparin or fondaparinux. Thank you.
Now we shift to the next speaker, Professor Dr. Munir Nazal, with the evidence in venous intervention.
Thank you very much. And to follow on the subject of DVT, so I will talk about is there an evidence to help us to do venous interventions in general? I have nothing to disclose. These are the goals of the outline goals of therapy. What are the major randomized studies and which therapy? Generally, when we treat DVT, we have one of three in mind: to relieve the symptoms or reduce the chance of post-thrombotic syndrome. And we tend to say we are trying to preserve the functions of the valves. As we know, thrombosis is a mixture of three factors, and we need to watch that there are few of them, such as the vessel wall, we might not change with the treatment. If it originates DVT as a problem with the vessel, sometimes hypercoagulability and stasis. So which one of those are really reversible? So this is the question. So what we talk about provoked and unprovoked DVT in general. We tend to say we are trying to prevent post-thrombotic syndrome, which the incidence between 25 and 50%. It's a very wide incidence. And since we started doing research on venous many years ago, and Marzouk is sitting here from Kuwait, we were focusing on post-thrombotic syndrome mostly. Let's look at how frequent phlebitic or thrombotic syndrome. The 1 year in one study, 17.3%, and another study, 27%. So there is a large variation. The 5 years in one study, 28%, in another study, 47%. So why we don't agree on the post-thrombotic syndrome, and a little bit was touched by Dr. Mossad about this subject. These are the clinical features that were adopted by the Cavent study for post-traumatic syndrome, the symptoms and the signs. So a large number of those are subjective. So, and we see that in the clinic when you tell the patient, do you have pain? No, I don't have pain. Then you tell them use the stocking. Next time he comes, oh, I had pain, I didn't know that until I used the stocking. So a lot of those are subjective. I mean, the patient, it depends how he answered many of the scoring systems we are using. The other ones are the objectives that are measurable. And these are the ones actually like a venous ulcer, skin color changes, or some veins here and there. And they represent some features of post-thrombotic syndrome. The end point in general is to prevent post-thrombotic syndrome, to prevent venous ulcers down the road. And we use for that different studies. We use the CEP classification and the scoring system. These are the treatment modalities, and we are not going to go through all of them. I'm going to focus on the intervention other than surgery, because honestly, I'm mentioning surgery to say it has no role now. There is no role for surgery anymore. It's done. So whoever thinks it has because in 5 minutes you can put a catheter in the common femoral vein and suction the clot and you get rid of the distension until you find out what to do with the patient. So all depends, is it acute or chronic? We think sometimes the vein has acute DVT, but when we go inside, it's chronic really, and vice versa. All depends where is the DVT, because not all DVTs have to be treated. And we know that only 1/3 of the cases are proximal, which is a problem, and these are the ones we are focusing on. So it depends on most studies, randomized studies, meta-analysis. The randomized studies, actually 3 main ones, and they don't agree on anything almost. All of them, we will find out they agree we don't have a proof post-thrombotic is decreased. Routine use of the clot is not supported by any of the studies. But we need to know that in some parts of the world called the United States, they remove the clot from the femoropopliteal vein. You know why? Because of the implicit bias to make money. And that will never go away. Even I'm sometimes get the fault of doing that. And you need the good access for that. You need a good ultrasound. You need really to have a good system. You have too many of things to use. And if we look at the Kevin study, the open label randomized study, iliofemoral patency after 6 months was higher in the catheter-directed lysis than the medical. And the PTS by Villalta score 24 months was lower again in the catheter-directed lysis. And this is one of the few studies, but it achieved a very only 0.047. And it was a very large number of patients that were at the end looked at 209 out of the many they looked at. And these are the changes. So there was some changes in the post-thrombotic syndrome, improving in the Kevin studies. And bleeding was in 20 patients, so there was some complication. Prevent 1 PTS in every 7 catheter-directed lysis patient. So if you look at the cost, is it worth it? And we don't know at 1 year, 2 years, is it going to last after that? So the Kevin study, there is a 14.4 risk reduction, and there's some improvement, especially in extensive DVT. And the ultrasound was used to identify, but we ignored the pelvic veins. The ATTRACT study, even I'm going to skip those to show you in the ATTRACT study, look at the numbers. They looked at 11,000 or 28,000 patients. And they managed to find a very small number. So if you are going to exclude almost 10,000 patients to treat 1,000 patients, what type of treatment is this you are achieving? It doesn't mean it's not working. You mean very selective in those patients whom you are going to use. And there was some changes, but it was not. The summary of the ATTRACT study, proximal DVT might help, and symptom relief might help. PTS, it did not achieve much improvement in the PTS, and it depended on the quality of life, and they use again the catheter lysis. They did not use other methods such inari or penumbra on those cases. Yesterday we touched a little bit on this, that we have a large number of reasons for DVT. Which one of them are we treating? These are all things that we need to investigate as scientists to see why DVT is happening. So which one we are really qualifying or selecting and ignoring all the other reasons? This is the problem with DVT. So the biological reasons are major. PAVSS study came, again, similar results. Of course, intravenous DVT is out. Catheter-directed lysis might have a role, but nowadays it's not the thrombolysis that is important. It's what we are using with inari and other methods. That to remove of the clot, which is much better because you don't have an ICU stay. I'm going to go to the last part. This is actually one of the studies in which look at meta-analysis. It came to the same result. We don't have a proof actually PTS in the long term is helpful with that. We have one of our studies that we looked, this is back to the clot triever study, which is inari. The best thing about the inari study, it says actually you get rid of the clot, less bleeding, no bleeding, but there was no follow. It is a registry, it's not a randomized study. There are 2 randomized studies now running in the United States, and they, in general, some improvement, but we don't have a proof that post-thrombotic syndrome is one of the material. We looked at ourselves in one of the studies at all modalities, which one is better? And we found actually, this is our study, there's no difference between lysis, catheter lysis, angiojet, Terellis, all of them do the same if the patient has acute DVT. If the patient has chronic DVT, nothing works in those cases. So immediate symptoms might improve, short term might be there, proximal DVT, there is evidence, PTS, we don't have evidence, objective measures only, preserving the valve, we don't know what's the definition, how to preserve the valve, duration of symptoms is very important. How do we measure actually PTS? We don't have a measure. Long-term symptoms, how long is long-term? We know PTS, the longer you follow, the more PTS and ulcers can form. It is why association like ASH, which is a hematology organization, says you should not do it unless there is a good reason. So honestly, we don't have an evidence that PTS is prevented, but we have evidence symptoms are improved. That's why we have to choose the symptoms based on that. Thank you.
Next speaker, Professor Ayman Fakhri. He will tell us the step after CLACS.
Good morning, Mr. Chairman, dear friends. Congratulations for Vascular crew and Professor Moshat. Thank you very much. طيب لغايه ما نبتدي احب بس اقول اناونسمنت صغير. ان شاء الله سكرتيرة الجمعيه المصريه للعلوم الاوعيه موجوده، وافكركم بميعاد تجديد الاشتراكات. يا ريت الناس اللي ما جددتش الاشتراك تجدد. الانسه امها موجوده في اخر، ما تنسوش تجددوا اشتراكاتكم. ممكن اشتغل من هنا؟
هو ده شغال بس الفيديو هو اللي فيه بتاع حضرتك. هو ده اصلا الستارت بتاع حضرتك؟
لا
مش قوي. هو ده سلايد 1.
انا عارف بس تمام.
هو ده سلايد 1 وده الكلام اللي هنزل عليه.
تمام. من هنا بقى مش كده؟
لا هو بيغير.
Today I'm going to discuss the NCLEX, the next step in NCLEX. I wish I can I'm sorry. Okay.
السلايد بتاع حضرتك، وبعد كده حضرتك لما تكليك على دي هينزل بقى الكلام نيكست.
تمام. I wish I can help Miss Barbie to get off her varicosity. I don't have disclosure. The purpose of CLACS technique is achieve efficacy through synergy between transdermal laser injection chemotherapy and skin cooling, as transdermal laser can perform selective photolysis. Why laser? As you know, laser could induce vein cooking. That means 50% diameter reduction. That's why it helps for the further steps. The question, is it real laser reduce the vein to 50%? الفيديو مش شغال. Okay. This is the video, and as you see, there is complete ablation of the vein. How can we inject occluded vein or abolished vein? So if we try to abolish and inject this vein, it will be a disaster. Are all these stars the same? No. As you see, there is red telangiectasia, yellow telangiectasia, and violet telangiectasia. So do we need different strategies for these veins? As you see, this is a mixed telangiectasia, the blue and red ones. We have two scenarios to abolish these veins. Either do sequential, two types of laser. This is KTB laser for red telangiectasia, and this is the Nd:YAG laser for the blue ones. Plan B, can we treat these veins, mixed veins by laser to abolish whatever the type of the vein, and the rest we can inject these veins, combined sequential presentation. And the question now, can we help this lady to get off her telangiectasia in one stage from this ugly state to the newer one? Yes, we can. We can use it by NCLACS, navigation, cryolaser, cryosclerotherapy. You will see that through this technique. Now we see we're using our instrument, and viewing, we only reduce 50% of the diameter. So now we have a chance to inject the rest of the lumen and achieve the best result. What our recommendation now? We repeat what Ms. Barbie is saying. Let's go for the newer technology, and together we use navigation, cryolaser, cryoclax. Let us use exothermal laser with navigation to create your procedure better and see what are you doing to ablate the veins and then sclerose the rest. Let's go for NCLACS. Before I go, I would like to invite you all to the 11th International Congress of Egyptian Venous Forum and 9th Congress for Venous Surgery Department in Dumyat in Steigenberger Hotel in Russell Park, 2nd, 3rd days of May 2024. Please come and join us. Thank you.
We call Dr. Mamoun Al-Bashir from Jordan, Endovenous Glow, case series 100 case.
Good afternoon all. It's always a pleasure to be in our second country, Egypt, and I'm going to talk to you today about endovenous glow ablation. We're presenting 100 cases, case series out of our many cases. And before we get into it, let me remind everybody that venous surgery was started by the father of modern surgery, Al-Bukassis, Abu Muhammad Qasim al-Zahrawi, who 1,000 years ago put down the description and the performance of venous surgery as we do it and know it today. So his procedure, which was done 1,000 years ago, is still being done, which is the ligation and the stripping of the varicose vein. Varicose vein interventions have gone through a process of advancement. So for many years, decades, we've been doing ligation stripping. We developed into sclerotherapy, into endovenous laser ablation, RFA, microwave, MOCA, and one of the most recent advances has been glue. And the reason we do all this is because if the advanced complications and the symptomatic format of venous disease, we're essentially treating one of the main features of venous disease, which is reflux, because venous reflux is a serious progressive problem and disease. And it's the main criteria in our center for treatment. So if somebody, regardless how much varicosities they have, dermal or otherwise, if they don't have reflux, we do not undertake any of these procedures. And you can see from the progression of endovenous procedures over the last 10 years how this sort of developed more and more into higher percentage of interventions and numbers with endovenous ligation injection sclerotherapy, and to the detriment of surgical ligation and strapping. And the main reason is because of the good results we've been achieving with endovenous therapy. Coming to glue, glue is N-butyl cyanoacrylate, which is a molecular formulation that has been known for many years, have been used in embolization for a long time. However, the newer formatted consistency of this has been used in endovenous therapy for about 10 years now. And from the ASVS, there is good recommendation and evidence that it is an effective way of venous closure and treatment of superficial venous disease. And the main advantage it offers is that it's local anesthesia, non-tumescent, so there is no discomfort, assumingly, and there is no compression post procedure, and as such is being done as a day case procedure. So it has two main advantages really. There is no compression after the procedure. In addition, you do not need tumescent anesthesia or any form other than local anesthesia. And if in comparison to all other formats, including endovenous thermal ablation or MOCA or sclerotherapy, these two features, the absence of tumescent and the fact that you do not need compression, in addition to the low risk of nerve injury, have been quite an advantage for glue procedures. That's why, the main glue device been used, Medtronic VenoSeal device, with literature on that, have shown that the vein occlusion rate at 3 years at about 88%, and the improvement in the venous clinical severity score is quite significant at 3 years as well. When it compared to thermal ablation methods, including radiofrequency, it's almost similar rates at 5-year closure rates. If freedom from recanalization is also similar to thermal ablation methods, and that's been sort of a driving factor, an encouraging factor for the more use of endovenous procedures. In addition, the reduction in the venous, the clinical score, severity score, has been equivalent to the thermal ablation. So let me take you through our own series. So our center is called Vascular in Oman, and we do a lot of procedures in the center, venous being one of them. From 2018 until 23, you've done a lot of procedures, but glue we've used 100 veins, and these were done in 64 females, 27 males. None of those were bilateral, most of them long saphenous, and very few, 7 of them were short saphenous veins. We use actually the Turkish glue, and we've used 2 devices, the Vena block and the Variclose. Most of these were done with the Vena block. It's an excellent device, and it has advantages over the VenoSeal. There are mainly 3 of them. Price first, because we're in private practice and price matters. Second, they do have a guiding light, so the endovenous insertion of the catheter made it easier by this light. And third is there is a speedy form of doing the procedure without using the gun, where it literally takes a minute to do the whole procedure once you gained access into the vein. We've recently used into Variclose, which is another Turkish glue company. Has slightly different. It has a double catheter format, with the main catheter being 3 centimeters ahead of the advancing catheter. It has no light. The glue itself tends to have more of a thermal effect, so the patients feels it more at the time of insertion, but it's equally effective. They do, warn of the potential side effects, and they're quite, there are a lot of side effects because it's a chemical material that you're injecting into a vein. The basic principles is simple. You're literally occluding the vein by bringing the vein wall together, permanently occluded while trying to cause as least thrombosis as possible. The procedure itself, and I do this with my senior sonographer, so it's a team effort where you need, well, first you insert the sheath under local anesthesia, ultrasound guided, while the sonographer is compressing the common femoral vein and the junction to prevent any of the glue going into the deep system. We're advancing the catheter about 5 centimeters away from the junction, and then injection, we do injection pretty fast with a pull-back mechanism. At the end of it, you're seeing the thorn, the crown of thorns appearance on ultrasound, which shows the occlusion of the vein. So in our series, we achieved complete closure of the veins intraoperatively in 99 veins. There's partial closure in one case, which was a large diameter vein. However, these usually progress into complete closure later. All cases were done under local anesthesia. Vena block used in 76 cases, very close in 24, and follow-ups is variable between 3 months to 5 years. And I have to point out, we do get a lot of medical tourism in Amman, Jordan, and some of our patients are lost to follow-up because they go to another country, so it's not all sort of comprehensive. Complications is what matters and what's bringing us to talk about this. We do get quite significant thrombophlebitis incidence, 21% in our series, and this is symptomatic thrombophlebitis. So a lot of patients do not come back with any symptoms, and they're happy with the procedure and they go away, but 20% of them will come back complaining of this thrombophlebitis. It's usually transient and it goes away with some compression and some analgesia and sometimes even some antiplatelet therapy or non-steroidals. We had one case of a minor vein perforation, and the glue, when it goes outside the vein, gives you even a worse reaction, and it resolves as well. DVT and thrombosis extension is the significant complication of cyanoacrylate. It happened in 3 cases in our series. In one, it was thrombophilia positive patients that we discovered later, and this is the same patient who had a minor PE. In another 2, one had a double deep venous system, and one of them was occluded. On subsequent scanning, however, it was recanalized again, and that's with full anticoagulation therapy, and in one minor extension, which resolves in full anticoagulation. Recanalization, and this is considering that we did not scan all 100 in subsequent time. We had 4 cases of recanalization. One of them is complete recanalization, and 3 were partial. We had no mortality or anaphylaxis. Why we are talking about this? Because there have been recent reports of events related to cyanoacrylate occlusion, and it's important that we keep modifying either the technology or the technique, or be aware of the potential complication. And this is the most recent paper that was just published a month ago. It talks about 899 serious adverse events, including 13 deaths, which is quite significant, to be honest. Most of these deaths happens because of anaphylactic reactions. All of these are to venocele, and it's quite important to be aware of the potential complications. We can go through all these complications, and some of them are quite horrendous, to be honest. They might include a stroke, anaphylaxis and death, DVTs with PEs, etc., etc. That's why the decision to make, which form of endovenous therapy you choose is something that you made with your patient, for them understanding the potential complications and being aware of them. So in conclusion, this is an effective means of treating endovenous venous pathology. However, newer data coming with possible complications probably makes us more aware of the potential and the need for advancements in these procedures. I encourage you all to join us in the Pan-Arab Vascular Surgical Society standalone meeting in Riyadh next month, which is sort of 2 weeks away. And I always finish with this prayer from inability to live all alone, from too much zeal for what's new, from treating patients as cases, and from making the cure of disease more grievous than endurance. Good Lord delivers. Thank you.
Thank you, Professor Mamoun al-Bashir. Now, decision making in KIVA recanalization by Professor Ahmed Gawish.
Good morning, ladies and gentlemen. It's a great honor to be with you and welcome you all in Alexandria, our beloved home base. So our talk today is about decision-making in KIVA recanalization. I have no disclosures relevant to this talk. Not quite infrequent that you face some patients that come complaining of abdominal wall varicose veins if they show you this themselves, or sometimes you can see those that patients do not tell you about it, but when you examine the patient, you have to expose the belly of the patient to, because sometimes the patient comes complaining from lower limb varicose veins and you find this nasty abdominal wall varicose veins as well, which denotes inferior vena cava obstruction, whether partial or complete. And the causes of IVC obstruction are either non-thrombotic external compression of the IVC, or can be due to, of course, deep vein thrombosis. Can also be iatrogenic, either due to filter thrombosis or the historical surgical clipping that was done in the old days. Also, you have to be aware that in young age you have to suspect anomalies of the inferior vena cava. And finally, it can be a post-thrombotic occlusion of the IVC. So these are the main categories of IVC obstruction. So our algorithm doesn't differ much than any venous case. When we face any venous case, we have to take history examination to answer the first question, is the patient having venous complaint? And then, if so, we do a duplex scan and analyze the results, the clinical and duplex data, to see if the patient has signs of obstruction, and if so, we go for advanced imaging. In our center, we use direct CT venography in that case, and we interpret the results and to find the answer about is the patient has reconstructable pathology or not. And then we start planning the procedure, and then we assess our outcome after that. So this is mainly our way of doing things, treating the right patient and choosing the right lesion to treat, and also doing the right procedure. And there are two schools. Some people, when they diagnose obstruction, they go directly to the cath lab and do an IVUS guided procedure. But our way, we prefer to have a pre-plan. As we said, we do a direct CT venography in all cases. We always pre-plan our cases before going into the angio suite. And then we can use IVUS or not. You can pre-plan everything that you don't need IVUS doing your procedure. So pre-planning for caval obstruction, for caval reconstruction, you have to assess using the CT, the lesion extent, the sizing, take accurate measures, plan your access, plan everything. It's an EVAR-like planning. It's not just looking at the nice images that they give you. You have to go for the axial sections and pre-plan every single detail before going into the procedure. And this is what I mean by EVAR-like planning for all venous disease. We take the measurements, we do the axials and the longitudinal sections, the MIP images, and we do everything that we have everything pre-planned. We don't rely very much on what we see in the venogram because it can be very much deceiving. So this is a case to show you how we plan our cases. This is a 40 years old female patient, came complaining of left swollen lower limb, recurrent attacks of bilateral lower limb DVT as well as bilateral lower limb varicose veins. She had also reported chronic pelvic pain and heaviness with deep dyspareunia. She had a past history of recurrent attacks of DVT, so it was definitely post-thrombotic. And we did a duplex ultrasound and CT venography for that lady, which showed that the patient had post-thrombotic stenosis of a long segment of infrarenal IVC. extending to both iliac veins with the left fem-pop segment as well involved, with huge left ovarian vein as you can see in the image. So this is to make things easier. We developed an acronym to plan cava recanalization. A stands for access. You have to plan your access very well before going in, because it can either lead to successful procedure or failure of the whole procedure. If you go into the collaterals and you do a bad access, that makes you a failed procedure before you even start. Anesthesia, we always prefer general anesthesia for those lesions. You have to have a good inflow and outflow. The measurements, as you said, you take all the measurements before going in to plan which size of stent and which length you would put in. The stenting configuration, as we will mention later, you have to plan how you will reconstruct the iliocaval segment, and sometimes you have to consider at some areas you may need sharp recanalization. Also, you have to be ready for double access. You might need to scrub the internal jugular vein because you might need it. Overlapping of the stents have to be taken into consideration when you measures, with your measures. And finally, tracking. You have to have a track to find your pathway in and don't get lost in the collaterals that you see in those cases. So these are the main, and you have to realize that arterial is different than venous occlusions. In venous occlusions, usually you don't have a subintimal plane, but you usually have those minor holes, as you can see in the image, that you can see. It's not about the force you use on the wire, it's about just be patient and track your wire correctly. You will find your pathway through even the nastiest occlusions like this. So these are part of the planning. As you can see in that lady, we pre-planned everything before going in. We planned the access to go through the left mid-femoral because the common femoral vein was involved on the left, but we planned to go on the right side through the common femoral vein because it was not involved. So this is planning the access. And these are the different configurations you can use for reconstructing the iliocaval outflow. And we started to prefer the skip stent technique downwards, which some of them, it's actually a little bit to describe, but it actually entails putting a large stent in the IVC till the confluence, and then putting the two stents in the iliac, not inside the one, because if you put it a 24 millimeter size stent and you put inside it 2/16s, for example, then you have a size discrepancy. So we prefer to skip an area, and we've done it in some cases with very good results. So that was our plan for that lady. That's the venogram on the left, and then we went in, putting pre-dilatation is mandatory, and then we put a long Abre stent, 18 by 150, till the confluence itself, and they, as you can see, we put the stent, as you can see on the right, till directly to the confluence, and then we continued the procedure by balloon dilatation and putting the other stents, stenting the left side till the inguinal till the common femoral vein, and on the right side only one stent to stent the post-thrombotic iliac. So we were sure that we stented from healthy segment to healthy segment using this configuration, and that's what we use. The venous stent 18 by 150, on the right side one stent 14 by 90, which is not inside the caval stent, and the left 3 stents till the common femoral, and that's it. Anticoagulation, we usually give low molecular weight heparin on table. We started with the patient on table. Post-operative, we keep 3 weeks low molecular weight heparin, then we shift to DOAX after that. In some cases, we may consider continuing anticoagulation lifelong. So these are the AIMS dot is actually our planning for success for every caval obstruction. And final words that I remind myself and you with our great friend Dr. Isam Osman, may his soul rest in peace. Thank you very much.
Thank you, Professor Ahmed Gawish. Okay, and my deep condolences for Dr. Isam Osman. I have a good news for you. We'll continue the session and we'll do Goma prayer after the session here in the conference room, so we don't need to go to the mess. Next speaker, Professor Ayman Abdel Fattah. Professor Ayman Abdel Fattah, the head of the vascular department in Shams University. He will talk to us about inferior vena cava filter insertion, evidence-based practice. Please.
Good morning, everybody. First, I want to thank the organizing committee for their kind invitation. I will speak about IVC filter insertion as evidence-based practice. Although most patients can be managed safely with anticoagulation regarding VTE, inferior vena cava filters represent an important alternative to anticoagulation in a small subset of patients. IVC filter use has been exponentially expanded with the advent of retrievable filter. Indications for IVC filter insertion have liberalized despite limited evidence supporting this practice. Because the indiscriminate use of IVC filter can be associated with net patient harm, knowledge of the risks and benefits of these devices is essential to optimal evidence-based practice. Inferior vena cava filter placement can be grouped in two categories: therapeutic indications for non-VTE and prophylactic indication for patients labeled as high risk for VTE. The therapeutic indication, therapeutic IVC filter for acute VTE with contraindication to anticoagulation is the only consensus indication for routine IVC filter placement. In some cases with therapeutic anticoagulation is temporarily contraindicated, prophylactic dose of anticoagulation with titration to a therapeutic dose may be preferable to IVC filter placement. For cancer-associated thrombosis, because the hypercoagulable state of cancer affects in all vascular beds, renal therapies such as inferior vena cava filter are likely insufficient for prevention of recurrent thrombosis and may be thrombonic by itself. Evidence-based guidelines recommend against the use of IVC filters in cancer-associated thrombosis outside the classic indication. Interruption of anticoagulation. IVC filter has been proposed for major surgery requiring interruption of anticoagulation, and clinician must determine if the surgery is urgent or elective and the necessary duration of anticoagulation. If surgery can be delayed to allow completion of 3 months of therapeutic anticoagulation, or if anticoagulation will be held only for a short period of time, less than 48 hours, aggressive pharmacological prophylaxis with dose escalation to therapeutic doses may be preferred than IVC filter placement. If the surgery cannot be deferred in the setting of recently diagnosed DVT less than 30 days, and the retrievable IVC filter can be considered, and a systemic plan should be delineated before insertion to ensure timely removal and avoid filter being left indwelling permanently. For prophylaxis, inferior vena cava filter placement for primary VTE prophylaxis is controversial, but accounts for more than half of IVC filter placed in United States. Incidence of pulmonary embolism is highest within 1 month after bariatric surgery and may occur despite pharmacological prophylaxis. Randomized control trials didn't show any advantage of using prophylactic IVC filters. In major trauma, VTE account for up to 85% of patients without thromboprophylaxis. Although pharmacological prophylaxis is effective and recommended by evidence-based guidelines, many patients with trauma have ongoing or perceived risk of bleeding and are not considered to be candidates for initial anticoagulation. There is 3 meta-analyses and 2 randomized control trials didn't demonstrate a reduction in fetal pulmonary embolism or death rate with prophylactic IVC filter placement in patients with major trauma. Prophylactic IVC filter also have unproven benefit perioperatively in patients undergoing high-risk orthopedic surgery like spinal surgery, total hip or knee replacement, and therefore they are not recommended. This table actually summarizes the evidence across different societies in placing IVC filter. There is consensus disapproval for IVC filter placement when there is no contraindication to anticoagulation. And there is consensus approval for IVC placement filter in all societies as regarding the presence of VTE with contraindication to anticoagulation. This is including NICE 2020. As regarding patient with complication with anticoagulation therapy or failure of treatment, recurrent VTE despite of therapeutic anticoagulation, there is no consensus approval. Actually, this is approved by or supported by the American Heart Association and American College of Cardiology, and supported by the NICE 2020, but with Class C evidence, and they said it may be appropriate when other options are expired. As regarding prophylaxis for IVC filter, whether bariatric surgery or major trauma patient or high risk, this is only supported by few societies, including the European Society of Anesthesiology and the American College of Radiology. Why we have to use evidence-based practice in IVC filter insertion? Because this procedure is not free from complication. We have to weigh between the benefit and the risk for the patient. IVC filter-related complications may be immediate complications like insertion problem, pneumothorax, air embolism, carotid artery puncture, arteriovenous fistula, or insertion site hematoma. May be early insertion site thrombosis or infection, or late complication like filter migration, IVC penetration or perforation, filter or IVC thrombosis, recurrent DVT, pulmonary embolism despite of filter placement, post-thrombotic syndrome, filter tilting or fracture, or entrapment of guide wires. To conclude, Mr. Chairman, ladies and gentlemen, I make it in do, doubt, and don't list. Do, we have to evaluate the risk benefits of anticoagulation before considering IVC filter placement. Assess regularly the safety of resuming prophylactic or therapeutic anticoagulation in those with initial contraindication. If you decide to place IVC filter, put it retrievable IVC filter, and then decide the time for retrieving of this filter. Document the systemic follow-up plan for retrieval at the time of IVC filter insertion. Schedule periodic assessment for filter integrity and complication. Report IVC filter complication to FDA MyUD database. Remove retrievable IVC filter as soon as pulmonary embolism risk subsides and or anticoagulation can be resumed safely. Refer to center with expertise in advanced retrieval techniques if standard techniques fail. Doubt, benefit of routine IVC filter placement for extended indication like catheter-directed thrombolysis for DVT, massive pulmonary embolism, surgery requiring interruption of anticoagulation, or free-floating DVT. Doubt, benefit of long-term anticoagulation for the sole purpose of indwelling IVC filter. Don't place IVC filter for primary VTE prophylaxis in high-risk patients. Don't place IVC filter in hypercoagulable patients outside the classic indication. You don't use permanent IVC filter because most patients have only temporal contraindication to anticoagulation. To summarize, acute pulmonary embolism and DVT with no contraindication to anticoagulation, no IVC filter placement. Primary VTE prophylaxis for high-risk patient, no IVC filter placement. Acute pulmonary embolism, DVT, contraindication to anticoagulation, IVC filter placement is indicated, and put retrievable IVC filter and plan for retrieval time when you are inserting the retrievable IVC filter. Thank you.
Thank you, Dr. Ayman. Now we get to the last speaker in this hot session, Dr. Walid Khrieba from Azhar Dumyat. He will talk about recurrent lower limb varicose vein, facts and facts.
بسم الله والصلاة والسلام على رسول الله. Main objective of this presentation to have uniformed, clear definition of recurrent lower limb varicose vein, to use it in research. And so recurrent lower limb varicose vein, by definition, lower limb varicose vein is a primary or secondary permanent pathological dilatation more than 3 millimeter of truncal and or extratruncal lower limb varicosity, not necessary to be elongated or tortuous. What about venous system of lower limb? It divided to superficial one and axial or deep one. Superficial one include truncal and extratruncal. Truncal include great saphenous vein and small saphenous vein. Causes of lower limb varicose vein may be primary or secondary. Diagnosis is done at ease by clinical and duplex study. Treatment of lower limb varicose vein. Endovenous or open surgery for varicose vein is commonly performed for indications that range from cosmetic concern in young or middle-aged women to treatment of extensive ulceration in elderly patients. It's essential that the patient are well informed about. Informed consent is very, very important to be discussed with the patient. Possible risk, discomfort, restriction, and all the details about the procedure and the different modalities before making their decision. Different modalities including conservative treatment, surgical treatment in the form of open or endoscopic, endovenous in the form of thermal or chemical ablation, or hybrid treatment. What about the definition of recurrent lower limb varicose vein? Recurrent varicose vein are common and costly problem with a negative impact on quality of life. At the International Consensus meeting in the Paris in 1998, recurrent varicose vein after surgery were defined as the presence of varicose vein in lower limb previously operated for varices with or without adjunct therapy. The consensus describe recurrent varicose vein in 3 forms. The first one is residual varicosity, true recurrent varicose vein, new varicose vein, which can affect any statistic analysis in any study. We must have one definition for recurrent varicose vein, uniformed worldwide, to use it to have a real work, to have good or excellent guidelines in real practice. Recurrent varicose vein after surgery have been, this slide according to European Society of Vascular Surgery, the last edition in 2022. Recurrent varicose vein after surgery have been defined as a newly appearing clinically obvious varicose vein, which is a logic in the case of patient. If you treat patient with great saphenous vein varicosity and come back after 1 or 2 years with small saphenous vein varicosity, according to this definition, this patient has recurrent varicose vein, which is actually not recurrent. I don't treat small saphenous vein before that. And the term is replaced by presence of varices after interventional treatment to include endovenous treatment, and conclude the discussion in European Society of Vascular Surgery. They use a newly formed varicosity on all the discussed subject in the last edition. What about the incidence? Due to we don't have one definition, uniform definition in all research, we can talk about the incidence and the prevalence of this subject. In Rutherford last edition, 10th edition, 12 group reported in randomized controlled trials, and to escape those rapidly. In randomized controlled trials in Rutherford last edition, the conclusion that they found no difference between open surgery and endovenous treatment in late result. In the early result in the first months, the randomized controlled trials that decides that endovenous treatment improves the quality of life in the first months, but after the first months, no difference between open surgery and endovenous treatment, especially in the recurrence, no difference between both, and this is decided and reported in Rutherford 10th edition. As regard the recurrence, they decide that if have recurrence in open surgery due to new vascularization, as well as we have recurrence in endovenous treatment due recanalization, as equal as in number without significant difference. And so the pathophysiology or possible mechanisms of recurrent varicose vein is ductile error, technical error, new vascularization, progression of the disease, recanalization of the diseased vein. Ductile error due to failure to identify reflux, technical error, failure to correct reflux, new vascularization, multiple new small tortuosity vein in the anatomic proximity to previous venous intervention. A progression of the disease, chronic venous disease is a progressive and systemic disease, and this is one of the most important point should be discussed with the patient during having the informed consent. Diagnosis of recurrent varicose vein can be done at ease, depend on clinical and duplex study. Duplex study, the secret of management or treatment of recurrent varicose vein is the prevention. The primary prevention is the cornerstone of treatment. But if it's happen, duplex study to localize the cause, localize the site of reflux with good management of the reflux is the cornerstone to have successful treatment of recurrent varicose vein. Meticulous evaluation, proper decision making, successful technique, detection of the cause of the reflux and site is the cornerstone for proper management. To save time, I will escape those rapidly and go to home message. Varicose vein is a primary or secondary permanent or pathological dilatation more than 3 millimeter of truncal and extratruncal lower limb varicose vein. And I think that the definition of recurrent lower limb varicose vein should be recurrent lower limb varicose vein is anatomical and radiological development of varicose vein after clinical, technical and radiological successful previous ablation. No rule for recurrence with a skillful hand who stuck to golden rule of individualization of the patient according to cost effectiveness of the procedure after proper decision making with meticulous achievement of all steps of the operation which lead to clinical, technical as well as radiological success. Thank you.
Shukran, Dr. Walid. Now we come to the end of our session, and because we are so late, we postpone the discussion during a break, and now it is the time of Jum'ah prayer. إن شاء الله صلاة الجمعة هتبقى موجودة في القاعة هنا.